Repeated trauma leaves the amygdala on ever-present status. Right? I was working with a female veteran a couple years ago, and she was kind of laughing about it, but she was telling me about going to lunch with a group of friends, and they were all veterans as well. And she talked about they were kind of jockeying for position around the table, so everybody wanted a seat where they could see the door, right? And so that's an example of that, their amygdala being on that ever-present status, constantly looking for danger. What we also know is that chronic trauma results in a smaller hippocampus. So back in 1995, a gentleman named Douglas Bremer did a study with Vietnam veterans. And he had two groups of veterans. He had those that had been involved in combat and those who had more administrative duties. And he did brain scans on all of these guys. And what he found was the veterans that had been in combat had a smaller hippocampus. And the smaller the hippocampus also correlated to more severe symptoms. So he replicated the study again in 1996. And again in 1997 with women who had been chronically sexually abused as children. And so what we know is that the hippocampus is affected by cortisol not only in function, but in structure as well. Okay, questions so far? I know it's a lot to, yes?
This may be a little toughy and a little off topic, but
That's
the
okay.
hippocampus, has anybody ever looked at the hippocampus at baseline, prior? Is there more of a vulnerability to a PTSD type of a situation in someone who may have a baseline smaller hippocampus?
That's a good question, and I don't know. I know they're doing studies right now looking at resiliency. I think particularly the military is looking at studies like that and trying to figure out what makes some people more resilient than other people. One of the things we know about trauma is dose. The more trauma you're exposed to, the more likely you are to, be affected by it. One of the other things we know is age. The younger you are, when your brain is still developing, when you might be exposed to trauma, the more impactful that can be as well. I was going to say something else and it escaped me.
Would trauma include neglect for young children?
Absolutely, absolutely. Yeah, because there's an absence of, what you're talking about, Doris, is attachment and attunement, right? So if a parent is either emotionally neglectful, that affects the brain because, one of the ways our brain develops when we're young is by experience, right? Our experiences with our caregivers. And if they're emotionally neglectful, absent, right, that's traumatic for them. Or if they're neglectful, providing the basics of food, that's also going to have an effect. One of the other studies they've done, and this is back to your question about the hippocampus, is that they have done brain scans with people before and after EMDR treatment, and what they found is that the hippocampus can regain volume, so that just goes to speak to the idea that trauma is very treatable. Most people don't think about it as that way, but if you're using the appropriate treatment, it is very treatable. And you had a question?
Yeah, that's encouraging. I was going to ask if two people with, say, a small and a large hippocampus might have, the same size hippocampus, could they have different efficiency or function from those hippocampi?
I don't know. So if somebody had a large and somebody had a smaller hippocampus.
Well, no, I misspoke. But
Okay.
If they have about the same size.
If they have about the same size hippocampus.
Could one be working better than the other?
Huh. Yeah, I'm afraid I don't know the answer to your question, so.
Do they use CT scans to measure that?
They do CT scans, MRIs, and fMRIs to measure that. Robert Stickgold is a professor of psychiatry at Harvard Medical School, and he's the director of the Center for Sleep and Cognition. And he published an article a couple years ago that really challenged the mental health field to relook at the way they look at PTSD. And what he says is that PTSD is categorized as an anxiety disorder. But he says anxiety is really just part of the diagnosis, right? I'm sorry, I didn't say that right. Anxiety is merely a symptom of PTSD. And he says that PTSD is really the reactivation of an unprocessed memory. And if we look at the continually unfolding neurological data, PTSD is really a memory issue, right? And so it's about these memories, these incidents that have overwhelmed the brain, and the brain hasn't been able to fully process them. And so we're starting to look at trauma as information processing stuckness. And a lot of times I have people come into my office and they really beat themselves up. And one of the things I hear a lot is they say, you know, I've worked on this in my 12-step program, I've prayed about this, or maybe they've even been to therapy before, and they say, why am I still stuck here? And so if I can explain to them, you know, this is not about some kind of character weakness on your part, or, you know, it's not that you didn't work hard enough, but something happened, there was an event that happened, your brain got overwhelmed and wasn't able to process it. And that's just how our brains function, right? And that's how my brain functions, it's how your brain functions, everybody's brain functions in the same way. And so sometimes giving them that information can kind of take away some of the stigma, you know, and how hard they're kind of flagellating themselves for struggling with a memory or an issue that's been there for years and years. And we're going to talk about the adaptive information processing model. And this is Dr. Shapiro's underlying explanatory model for EMDR. And it's about her explanation for why EMDR works and what's happening during the process of EMDR. It's also our model for why people struggle. It guides our treatment planning and also guides how we're going to intervene with our clients. And it incorporates all the unfolding neurological and psychological to date related to memory encoding, memory processing, and the impact of trauma. It's how we organize all that we know about our client. Okay. And so this is our current understanding of what EMDR does. So during our treatment planning, we will have identified an incident or a memory that needs to be addressed. And we ask a series of questions including sensory information that create a link to the traumatic memory and the maladaptively stored information. So the questions are, you know, what's the picture that represents the worst part of this incident? When you think of this incident, what's the negative belief about yourself? We identify a positive belief. When you think about this incident, what would you like to believe about yourself instead? We ask them how true the positive belief feels. We identify the emotions connected with the memory and the negative belief. We assess for how disturbing that is, and we ask for the body sensations. And what this series of questions does is it accesses all the fragmented parts of the memory and lights up the memory network. And once the memory is turned on, we begin doing eye movements. Okay? And the eye movements activate the information processing system in the brain and helps it begin to reprocess all the disturbing aspects of the memory. Okay. And it moves the information along the appropriate neurological pathways at an accelerated rate. Okay. And so what we've done is activate the brain to do what it knows how to do, to process the memory. And so we've turned the memory on, we've jump-started the information processing system, and repetitive sets of eye movements move the unprocessed information along. And after a set of eye movements, we check in with our clients. And we use the question, what do you notice? And what we want to know is, how is the memory held now? And what we're doing is we're following where the memory is going. And when we ask our clients, tell me what you notice, what our client may respond with is an aspect of the incident being addressed. They could report that they're feeling a certain emotion, related memories could be coming up for them, or body sensations. Okay. So the way we talk about EMDR is that it spontaneously accesses and metabolizes the associated disturbing material. And what we see is a spontaneous link to more positive adaptive memory networks. And this results in a full reprocessing of the memory. The disturbing material is eliminated or processed out, and there's a repair of the dysfunctional linkage. There's a positive shift in self-perception, previously reactive behaviors, and triggers. And this is our criteria for knowing how the entire memory has been processed. So number one, the client can turn their attention back to the memory and report that it no longer feels disturbing to them. The positive cognition that they want to hold in connection with the incident feels true. And when they think about the incident and hold it with a positive cognition, there's no disturbance in their body connected to it. Okay. So central to the adaptive information processing model is this, that any type of imbalance, dysfunction, is viewed as the result of a blocked ability to process related, frozen, dysfunctionally stored memories. Negative beliefs, affect states, and related behavioral responses are viewed as symptoms of unprocessed painful memories rather than a source of pathology. And so this is really a rethinking of what pathology is. You know, somebody, Janie was asking me during the break if I was going to talk about assessing for PTSD, and what I told her is, you know, this is how I conceptualize what people bring to my office. You know, if somebody comes to me and says, you know, I've been struggling with depression, what I start looking for, okay, what are the memories that need to be processed? What are the incidents connected to this person's depression that are still frozen in their nervous system? And so I told Janie I really don't think in terms of a diagnosis anymore, and I said I'm allowed to get away with it because I don't deal with insurance companies, so it gives me the freedom to do whatever I want. So there's a woman in the EMDR community, her name is Sandra Paulson, and she's been an EMDR practitioner probably since the very early days, and she has written several books on EMDR and working with dissociative disorders and very early childhood trauma. And one of the things she said at a conference, she said, if you take a DSM and you kind of shake out all the diagnoses that don't have at their root painful unprocessed memories, you know, what we're left with is a much slimmer DSM. And so I really like, you know, the way she talked about that. So it's a neat image to have.